Thank you all very, very much for coming to what is the 11th Lloyd Cox Memorial Lecture, which is, of course, jointly hosted by the Robinson Research Institute. My name is David McIntyre. I'm a Professor of Reproductive Systems Medicine here at the University and also Director of the Robinson. So we'll begin tonight by, of course, acknowledging that we're meeting on Kaurna land, and we respect their special relationship with the country. We also acknowledge that the Kaurna people are the traditional custodians of the Adelaide region and acknowledge their cultural and heritage beliefs are still as important to living Kaurna people today. I'd also like to begin by thanking some of the special guests that have taken time out of their busy schedule to join us here tonight. We have Catherine Hutchison, MP. We are also joined by the Honourable Grace Portalesi, who we are aware of being here now. Thanks, Grace. Former Minister for Education and Child Development. We have Mr. David Cox, who is, of course, son of Professor Lloyd Cox and the namesake of the lecture. Our keynote speaker, of course, Professor Danielle Mazza, who I'll do a proper introduction for shortly, and all of our other Adelaide University staff, students and alumni, and other distinguished guests. I must do a couple of quick housekeeping items. If there is an emergency, we'll ask you to leave via the stairs and head towards the emergency exits, which are just on the other side of the cafe, just here, Bean Bar. And I'll just give, for those of you who are unaware, a little bit of context and a bit of background about our institute. We are one of Adelaide University's 8 research institutes. We are, of course, focused on supporting reproductive, pregnancy and early life health. And, of course, we're trying to achieve that through research excellence that we then translate into clinical care, policy and practice. We're really proud to be hosting this Memorial Lecture series, which brings some of the most inspiring researchers from around the world here to Adelaide to present on various different thought-provoking topics. The lecture series is named after Professor Lloyd Cox, who in 1958 was appointed as the Foundation Professor of the University of Adelaide's Obstetrics and Gynecology Department, which was then established at the Queen Elizabeth Hospital. Professor Cox had previously worked in New Zealand and the UK, and his vision was for the department to be a world leader. He had a very strongly held belief that science and medicine should collaborate closely. And he really established the foundations for future successes in this way by creating this culture of collaboration that we've been continuing to follow. Cox also wanted ONG to be a science-based department. And he was indeed the first person to bring infertility as a medical issue to the attention of mainstream medicine. He encouraged people to look at new ideas, develop new techniques. During his time as the head of ONG, he also appointed Ron Cox as a biochemist, and that was the first department of its time to appoint a scientist in a role like that. He also helped establish the first frozen semen bank and the first sperm donor programs here in Australia, so an incredible legacy he leaves behind. He retired in 1984. And the namesake of our institute, Professor Geoffrey Robinson, became head of department, while Colin Matthews was then appointed as the Professor of Reproductive Medicine. So with that little bit of history, which provides us with some, I think, important context as to the type of work that we're trying to achieve now, I'm very happy to introduce you to our speaker, Professor Danielle Mazza. Professor Mazza AM is the head of the Department of General Practice at Monash University and a nationally and internationally recognised leader. Did I say Monash? Is that correct? Yeah, but you were at Melbourne. Yeah, that's why I keep getting confused. I want to make sure that I got it right. Monash. Internationally recognised leader in implementation research and knowledge translation in the general practice setting. She's made significant and sustained contributions to advance general practice and primary healthcare in Australia, particularly in the fields of women's sexual and reproductive health. She's also a proponent of evidence-based quality improvement through guideline development and implementation. As such, she leads the Sphere Centre of Research Excellence, which I know she'll be talking a little bit about today, which aims to improve the quality, safety and capacity of primary healthcare services to achieve better outcomes in women's sexual and reproductive health. Now, just before I invite Professor Mazza to the stage, we're going to be taking questions at the end of her presentation using the traditional microphones being carried around at the end. but we also will be offering you an opportunity to provide questions throughout the presentation. So we're going to use a program called Slido. If you want to take out your phones, which I'm sure you all have, there's a QR code there that you can scan. That will take you to a page where at any stage of the presentation tonight, if you have a little thought, an idea, a comment, a question that you may want to raise, we invite you to just pop it down there in a short format. You can leave the question anonymously if you're a little shy and you don't want to have the question attributed to you. That's totally fine, and we'll get to all of those questions in the question time. So with that, I'm absolutely delighted to welcome Professor Danielle Mazza to the stage to deliver her lecture entitled From Aspiration to Access, Building Equitable High-Quality Women's Sexual and Reproductive Healthcare in Australian Primary Care Settings. Thank you so much.
Okay, can you hear me all right? Well, it's a real honour to be asked to deliver this very prestigious lecture at the Robertson Research Institute, which I have admired from afar for many, many years, for most of my career actually. And tonight I'm going to be talking to you about trying to improve access in women's sexual and reproductive health services through primary care. And I too would like to acknowledge the traditional owners of the land on which we're meeting today and pay my respects to elders past and present. I'm very fortunate to work with a fantastic team of investigators and researchers and have wonderful students also with me in Sphere. And I couldn't start the lecture without acknowledging the many contributions of my collaborators. Monash University has a fantastic conference centre in Prato in Italy, and we've been very fortunate to meet there a couple of times to ponder our research and make plans for the future. And much of the work that I'm going to discuss with you today has arisen out of those meetings, so I thought I'd put in a couple of photos of the team. But tonight what I'd like to talk to you about is the importance of unintended pregnancy in Australia and how that's driven the research that I've been undertaking and where that's led to in relation to improving access to long-acting reversible contraception and medical abortion. And I'm also going to talk to you about some of the tools that we've used within our Sphere Centre of Research Excellence to achieve the policy and practice change that we've been able to, and what's left to do, because there's lots. I spoke to the EMCRs earlier, and they asked me what's kind of driving my research, why am I doing what I'm doing? And I think for me, I've always been very interested in women's health, because for me, the ability to control reproduction is such a fundamental issue for women's lives, just as much today as it was for my grandmother and my mother, and for all of the women in the audience today, and for all of the men, all the women in your lives as well, your wives, your mothers, your daughters. Really, it's such a fundamental right to have the number of children that you want when you want them. And personally for me, in my family, I come from a religious Jewish family, and I have a cousin who's my age, who was at school with me, who was married at the age of 16 and pregnant, doing her VCE, and went on to have 7 children. You know, when I meet with her and we exchange stories of how our lives, the impact of her trajectory, having so many children, she was the clever one, not me, and what I've been able to achieve in my career are so starkly different. Not that I'm devaluing her role as a mother to her beautiful children, but it's fundamental. It changes women's lives. And so really, if we want to provide women with this reproductive right, They need to have access to effective forms of contraception to prevent pregnancy, the ability to access safe abortion when required for unintended and unwanted pregnancies, and very importantly, access to preconception care to optimise the pregnancies that they do have. But tonight I'm going to focus on the first two of those, contraception and abortion. And I want you to consider the burden that women have in trying to control their reproduction. We know that in Australia the average age of first sexual intercourse is 16. The average age of first-time mothers around 30, although that's climbing. And the average age of menopause is 51. So if women are planning to have 1 or 2 children, they spend about 5 years pregnant, postpartum, or trying to conceive. That's 30 years, 30 bloody years, trying to control reproduction and trying to avoid pregnancy. And at the moment, they're typically doing that with contraceptive methods that have quite a high failure rate. The commonly used contraceptive pill has rates of failure of around 9% or higher per year. So we, despite being such a wonderful and brilliant country, we still have a huge amount of unintended pregnancies compared to other countries and the world leaders, probably the Netherlands. 40% of all pregnancies in Australia are unintended. And this has repercussions not only in terms of live births. As I said, it's not that unintended pregnancies are all unwanted, they are just unplanned. But it also means that there are miscarriages, stillbirths and abortions, and the costs are around 7.2 billion to the Australian economy. But unintended pregnancies are not equally distributed in the country. We know that about 1 in 4 Australian women have had an unintended pregnancy in the last 10 years. And the thing that doesn't change is the numbers that end up in abortion, which is pretty uniform across developed countries. So it's the numbers of unintended pregnancies that differs between countries. So in Australia, about 30% of unintended pregnancies end in abortion. Women in rural areas are 1.4 times more likely to experience unintended pregnancy, and we can ponder the reasons for that. And younger people are also much more likely, with 41% reporting an unintended first pregnancy. So if we think about how we're going to deal with this, who's going to deal with it? And I would say that we've got 6 million women of reproductive age in Australia. That's a hell of a lot of women to provide healthcare services to. It ain't going to happen in hospitals. We really need to rely on primary care to be able to deliver the services to assist women to deal with these issues. And currently, if we think about the workforce that we're dealing with in primary care to do that, there's about, I'm getting these figures, I think I got them from the medical board, and there's 36,000 GPs currently registered across the country. That's a lot of GPs that you've got to change their practices for, so you've got to be thinking about your strategies of how you're going to change things in general practices. 13,000 general practice nurses and 16,000 community pharmacists. And as I was explaining to the EMCRs earlier today, general practitioners in Australia work in small businesses. They are not working in big hospitals where there is clear policies and protocols and standard operating procedures and a hierarchy of doing business. They're small businesses, they're independent practitioners, they work predominantly fee-for-service using Medicare, which is both a benefit and a constraint. And so this is the issue for us. We need to be able to provide access to contraception, particularly to these young women. particularly to rural women. And we also need to be able to provide them with abortion services when they're needed. And so this was our argument with Sphere, our Centre of Research Excellence. Back in the day with Sphere Mark I, when we first pitched for that, we went to Canberra and did an interview and convinced the panel that this was a worthy cause. And we are now in Sphere Mark 2.0, continuing our research and our policy and practice work. And our focus is really in several areas. We want to undertake research that informs policy, and we need to work very closely with the policy makers, both state government and, importantly, federal government. We want to increase health literacy and help those young women to access the services that they need. So we work closely with consumers. And we want to improve clinical practice, and so need to work closely with health professionals, colleges, multiple colleges, Pharmacy Society, Australian Practice Nurse Association, College of GPs, College of ONGs, Pharmacy Guild sometimes. So there's lots of different clinical partners that we need to work with. And we need to do all of that to get better outcomes for women. You can't really focus on any of these. It's a wicked problem, and you need this multi-dimensional approach. So for the researchers in the audience, I thought I'd put up this slide to show the journey, because the kind of work we do and the changes that we try to effect don't happen quickly. And our journey started way back 2014 with our first NHMRC project grant, which led on to Sphere 1.0, and what followed was partnership grants, MRFF grants, government grants, tenders, and along the way, if there's anyone who's keen, I would highly recommend trying to undertake a Churchill Fellowship, which I was very fortunate to receive prior to COVID, then did my Churchill travel after COVID. A Churchill Fellowship is awarded to investigate how things are done overseas and try and bring the lessons back to Australia. And it was a wonderful opportunity for me to go and ask the questions overseas of my colleagues about how they deal with this issue of improving access to contraception and abortion, what models they have put in place to try and address these issues and to bring back those learnings. And it's been a very powerful tool to be able to talk to politicians in particular, to give examples. Well, Canada's doing this, and look what they do in Ireland. Ireland, of all places, is probably implementing abortion care through primary care in the best possible manner. You wouldn't have thought so, but these are the kinds of insights you get when you travel overseas and see what's happening in other healthcare systems. Importantly, COVID was also a very big kind of factor, I think, in the ability of us to impact on policy, because COVID was a time where we were innovating very rapidly around health service delivery in primary care. And we, the sexual health research community, were terrified that women's health services were going to be cut and things like abortion become inaccessible by the demands of COVID. And so we came together and established what we called the Sphere Coalition to try and address the COVID challenges. And that coalition has sustained and I think become one of the most successful vehicles that we've got to drive consensus, to put to policymakers and to colleges and professional groups to try and drive change. So happy to talk a little bit more about the journey, but just wanted to give you an idea of all of the inputs that came in along the way. There was also a Senate inquiry that was launched into universal access to reproductive health care that we were able to feed into and talk to the policymakers and have our recommendations adopted through there. And I think what's been very satisfying is seeing the fruits of our labour in the women's health package that was announced in February in the lead-in to the federal election, and I'll talk a little bit about that too. So let me talk to you first about long-acting reversible contraception. Many women out in the community know very little about long-acting reversible contraception, or the fact that it is the most efficacious form of contraception that's available. It consists of the contraceptive implant and intrauterine devices, hormonal devices, and the copper intrauterine device, and it's more than 99% effective at preventing pregnancies because it's set and forget. It's long-term, it's reversible, it can last 8 to 10 years with the different products. Fantastic advance that has really revolutionised contraception. And that's compared to shorter acting methods like the combined pill or the vaginal ring, which are really dependent on the adherence by the user. And if you don't have any money to buy your next packet of pills, then you don't continue with the pills and you might fall pregnant. Or if you forget to take the packet of pills, you might fall pregnant. Or if you experience reproductive coercion and your partner hides the pills or throws them away, that also may lead to an unintended pregnancy. So it's very important to understand the efficaciousness of long-acting reversible contraception and talk to particularly young women about it who don't know very much at all. And in Australia, we have surprisingly very low rates of uptake for long-acting reversible contraception. About 11% when we last measured, 6.3% of women of reproductive age using a hormonal intrauterine device, 4.5% using the implant. And the international benchmarks are very different. The UK, 36%, Sweden, 31%, Denmark, 38%. Why is it so different, right? These were the questions that I was asking when I went over and did my Churchill. There's got to be a reason for it. Well, there's lots of reasons for it in the Australian context. And I like to divide these into system issues, provider issues, and consumer issues. We don't have enough providers. No one knows who are the providers. We don't have rapid referral pathways. We don't have any regional planning around making sure that this service is available. And if women are increasingly going to online services like online pharmacies, they're not even hearing about the option of long-acting reversible contraception because you can't put it in through a telephone. So there are also provider issues. A lot of GPs out there have old-fashioned ideas about IUDs, that they're not good for young women. They lead to pelvic infection, despite research overturning these outdated concepts. A lot of GPs want to get trained but can't find a place to get trained. And those that do get trained, GPs generally do low numbers. They're not doing it every day, all day. And so they may not commence after training or sustain provision. They weren't getting paid very well to do it, and there wasn't much peer support or mentorship. And for consumers, there was a real lack of awareness and high costs of consultations and lack of transparency, misinformation. Misinformation is huge in this space. If there's one area that's just, I don't even know the word, it's just overwhelming how bad it's not only misinformation in women's sexual and reproductive health, it's disinformation that's coming from those sources, more in the US, against reproductive rights, that is actively discouraging women from taking up these very useful and good products that are not only there for contraceptive purposes but also for the treatment of conditions like endometriosis. Right? This is one analysis that I'm citing of TikTok videos. You know, what do they say about IUDs? They're negative. They talk about distrusting healthcare professionals. They highlight pain without really explaining it, and they're really of very low quality. And you know, I like to test the water. You know, if I go to the hairdresser or I talk to the shop girl in the pharmacy and you know, start a conversation, you know, where are they getting their health information from? They tell me if it's not on TikTok, they don't know anything about it. So this is where consumers are finding out their information. So one of the first things we did within Sphere was try to address this, and we spent a lot of time. This was a women's health strategy grant that we got from the government. We did focus groups with women from different ethnic communities and young women. We asked them what they wanted to know about these products, and we developed these educational videos. We translated them, and we tested them out to see how effective they were at changing knowledge, preference, and whether that actually led to increased uptake. And as I said, the majority of both young women and women from CALD backgrounds, culturally and linguistically diverse backgrounds, had little awareness of LARC options and didn't feel well informed about them. Not unsurprisingly, after they watched this video, they reported increased knowledge and, interestingly, preference for IUDs. But when it came to uptake, we followed them up 6 months later. The young women, in general, managed to some extent to get an IUD, but in the CALD group, there was a trend, but it wasn't significant. So, and the numbers were pretty small. So this kind of indicates that even if you have knowledge and preference, you may not be able to actually access, and that's pretty problematic. So we did a trial to see what the impact of an intervention in general practice could be to improving access to long-acting reversible contraception. And we wanted to do the trial here to try and help policymakers think of strategies to increase uptake. This was a cluster randomised trial. It was called ACCORD. We did it in metropolitan Melbourne, and the intervention consisted of 2 parts. We didn't train GPs to put in IUDs. What we trained them to do was to do better counselling. You know, a young woman often comes in to you as a GP and says that, you know, they feel shy, they're nervous, you know, they're young, they don't have a good relationship with you as a GP yet, they don't know you very well. It's a very stigmatised area. They're probably worried their mother's going to find out, you know, I don't know. And they come in and they want to get out of there as quickly as possible. So they often say, I want a pill, I want a script for the pill. It's very easy to just give them the script for the pill and let them be on their way. But what you actually really need to do is you need to spend the time with them, explaining to them all of the options that there are. And that's what we taught the GPs to do. And we taught them to do that with an effectiveness-based approach. So rather than starting with the pill, we taught them to start with talking about long-acting methods first. Pull up your chair, and I showed you that card before with the pictures of all. So I have that on my desk, and I put it on the desk. Draw up your chair, let's talk about, maybe you don't know what's out there, something else might be better for you. Why don't we talk this through? You know, the most effective forms are these methods. How important is it for you not to get pregnant at this point in time? If it's really important, maybe you need to think about using the most effective methods. But then what are the other issues that are important for you? Bleeding control, is that important for you? Well, this does this and this does, and you go through in this very patient-centred way, but you start with the most effective forms first. We also gave the GPs an opportunity to do a rapid referral to insertion, particularly if they didn't do it themselves. If they didn't put in the IUDs or the implants themselves, they could book an online appointment with a gynaecologist that we hired. We booked out their sessions to do this. The control GPs just did their regular care, and look at the difference that we got. So we got rates of uptake of LARC of 44% by 6 months, 47% by 12 months, and we followed up the cohort at 3 years and 41% was still using LARCs. Now you can look at the control group and say, oh Danielle, you told us that the uptake was 11% for LARCs, but this is our control GP. When you do a study in general practice and you say, would you like to be involved? This is a study about long-acting reversible contraception. All the GPs who are already interested in contraception anyway put up their hands, right? But it's a randomised trial, so our intervention did make a significant difference in LARC uptake. And when we followed up the women, we were also able to demonstrate reductions in unintended pregnancy and abortion. So I went to government with those trial results, and I said, this is what we need to do. We need better training, we need the ability to do these rapid referrals. But we've got other issues that you also need to address. We've got very limited numbers of places for GPs and nurses to train in medical abortion and IUD insertions, because hospitals are not good training grounds for these kinds of skills anymore. Hospitals, I haven't been to hospital for a while, but they do procedures in hospital, surgery in hospital. There aren't many contraceptive clinics and GPs who train in hospital are usually doing obstetrics. They're not doing much gynae. There's laparoscopy lists, and I don't know. It's not contraception and abortion that's done in public hospitals, unfortunately. So hospitals are not good places to train. And if a GP wants to do IUD insertion training, it'll cost them on average $1,620 out of pocket. Do you know what the rebate is for an IUD, or what the rebate was for an IUD insertion? It was about $70. So how many IUDs do you need to do before you even, before it even pays for itself? And you're taking time out, you're losing income, and there's a long wait to do IUD training. I was also able to tell the policymakers that in other like countries, patients don't pay for contraception. What is it in Australia? How come we make people pay for contraception? So in the UK, it's free on the NHS. In France, if you're under 25, you don't pay. In Ireland, if you're under 30, you don't pay. Belgium, Germany, Norway, adolescents can get it for free. Canada's just introduced free contraception. So it's always good to talk about that kind of stuff, because then they feel, oh, we're falling behind, Why aren't we as good as those places? And we were also able to show them the kind of built-in gender disparities in the Medicare system. An IUD insertion, item number 35503, the Medicare rebate on that, $75. But if you do a vasectomy, have you ever seen a vasectomy being done? It takes 5 minutes flat, under local anaesthesia. I've done one. You get paid $215 for doing that. If you do a wedge resection of an ingrown toenail, $158 for doing that. The politicians love, sorry to the politicians, but you like seeing this kind of stuff, because this is the reality of the system, right? So we had the great fortune of having Jed Carney as Assistant Minister for Women's Health in the last few years, and Jed's a midwife, and she ran the ACTU. She knew how to build consensus and drive change, and she was fabulous. She took all of this on board, and she just blew us out of the water when she announced the women's health package that came in 2025, and that's currently being rolled out. So from the 1st of November, there's been an increase in the Medicare rebate. I told you before it was about 75, now it's about over 150, and there's a 40% bulk billing incentive for the consultation and the insertion on top of it. So it's not that, you know, it's not a gold mine still to do an IUD insertion, but it's much better paid than what it was a while ago. They've also introduced LARC training scholarships to incentivise practitioners to become inserters, so they don't have to pay out of their own pocket to learn essential women's healthcare services. They are establishing LARC centres of excellence in each state to enable the rapid referral for insertion, and they're also funding a contraception decision-making tool that's going to be publicly available through Health Direct. They've also done other brilliant things, working with the PBS to bring in new contraceptives. So we are very blessed, I think, to have this package come in, and I'm eternally grateful that Jed was such a fantastic person to listen to the research that we presented to her, to take that up on board and to translate that into really meaningful policy, I think. We've also, surprisingly, had some success with improving access to medical abortion, and let me tell you a bit of the journey there. How am I going for time? Okay. So, often when I go into government and I talk about abortion, it's like deer in the headlights. There's this terror that comes on the faces of people who don't really know what an abortion is, and don't know how common it is also. It's been such a stigmatised area, and certainly when I was growing up and when I was a young GP, it was something that never happened in general practice. So some of the rural doctors would be proceduralists, and they might do abortions on their lists in country hospitals. But as a city GP, you didn't even print it on your computer. You wrote it on a scrap piece of paper, you know, the phone number, call this number. You handed it over to the patient, who put it in their pocket and scurried away, kind of thing. And it was the number for the abortion clinic, you know, in the city, where they could go and get help. That's how I was taught about abortion. But things have come a long way, and now we have not only surgical abortion, but we have medical abortion, which is safe, efficacious, reliable, and bloody fantastic. Because it gives women the ability to undertake an abortion in the privacy of their own home, in the comfort of their own home, supported by their GP, and it's no harder than writing a prescription for any other medicine. So what it is actually is it's a medically induced miscarriage using mifepristone, which is RU486. Some people will remember it being called RU486, and misoprostol, which is a very commonly used medication. The mifepristone you take by mouth. It ends the pregnancy by blocking the action of the progesterone hormone that supports the pregnancy, and then about 36 to 48 hours later you take the misoprostol, which softens the cervix and contracts the uterus, and the pregnancy is expelled. It's been available in Australia for about 12 years now. But for those who don't remember, or there's a lot of young people in the audience, there used to be a politician called Brian Harradine, who was from Tasmania, who was very conservative, and Telstra was being privatised, and somehow that resulted in terrible stuff for mifepristone. And if it wasn't for very brave parliamentarians, bipartisan, led by fantastic women, country women, Liberal Party, National Party coming together, Mifepristone was brought into Australia, but there was all these regulations placed on it. And this excessive over-regulation meant that for your average GP, they thought twice about delivering this service. First of all, they'd never been taught about it. But secondly, there was all this stigma with this over-regulation, right? Why do I have to undertake mandatory training and certification and recertify every 3 years to be able to prescribe this medication? Why, when I ring up the authority prescription line, do some people at the other end hang up on me when I try to get an authority prescription for this drug? Nurses couldn't do it, and pharmacists also couldn't just dispense it like any other drug. They had to also register. What was it about? If there's so many funny rules about this stuff, maybe it's bad and maybe it's not good, and I won't kind of go there. So what happened is that hardly any GPs were undertaking service provision in this area, and we mapped it. We mapped who was providing medical abortion, and we mapped where pharmacies, where there were no GPs and no pharmacists. So this is in 2019, you're probably looking at South Australia, and at that time no GP and no pharmacist provided medical abortion because your legislation said it had to happen in a hospital, and thankfully that legislation has now changed and we can do it in primary care. But in 2019, look at all the eastern seaboard, Brisbane, Northern Rivers, Western Victoria, around Darwin, Perth. Look at all the places where not even one GP or pharmacist prescribed medical abortion. And I had a mate who was the College of GP president, and she got me in to see Greg Hunt, who was the health minister at the time, and I showed him this map. And I said, this is terrible. You know, 30% of women in Australia live in a place where they can't access a medical abortion. And to his credit, he responded. I was also able to show that my colleague Wendy Norman, who is my special friend and collaborator of many years, who is also a GP researcher working in this space. We have a lot in common because Canada is very similar to Australia with rural stuff. She was able to deregulate medical abortion in Canada, and she demonstrated in a beautiful paper in the New England Journal that if you deregulate, abortion rates don't suddenly skyrocket. Safety doesn't change, but what actually happens is that the number of providers triple. And rural areas have had a 12-fold increase in provision. So these were two pieces of evidence that I brought to the policymakers. And Greg Hunt introduced special MBS item numbers called for telehealth, sexual and reproductive health, telehealth item numbers, which are now permanent part of Medicare, which can cover any aspect of sexual and reproductive health, which have no patient restrictions, which allow a woman in WA to get an abortion from a doctor in Queensland or in Victoria or anywhere else, subsidised through Medicare. Fantastic stuff. And with Jed Carney, when I presented to her Wendy's work from Canada in the context of the TGA, with all of the TGA head and all of those people there, and I showed them the evidence about deregulation is safe, TGA moved to deregulate, and in August 23 all of that stuff was repealed, and provision is now open to nurse practitioners and endorsed midwives subject to state legislation, and the stigma now is gone, and providing a medical abortion is the same as providing any other prescription. You have a duty as a health professional to learn about what you prescribe, but you can prescribe it like any other drug. We've also been able to, recognising that this is a large amount of change, right? It's cultural change in general practice. It's their new products, it's cultural change, it's a new way of doing things. It's bringing abortion into what you do, basic women's health, essential health service delivery. We need to support our practitioners to be able to do that. You can't expect those 36,000 GPs across the country to suddenly adopt this stuff and move with it without supporting them. And what we did, again, with Wendy's help, because Wendy had done something similar in Canada, we applied for an NHMRC partnership grant to develop this online community of practice called AusCaps. And here we invite GPs, community pharmacists, practice nurses to come online. It's a bit like a Facebook group, but it's much better curated. And they can post their clinical questions and get answers from their peers and from experts. And there are people in the audience tonight from Shine. We use some of the doctors from there and nurses around the country and pharmacists who are experts who can answer the difficult clinical questions. And it amplifies everything because it's not just one, you know, if you're a GP and you ring up your specialist colleague for advice, you're the only person that hears that advice. But if you're on an online community of practice, there are 3,000 other people that can see that post. So the learning is exponential. We've got a fantastic resource library, webinars, podcasts, links through to training. It's been taken up with enthusiasm, and it was so successful that the government has now funded it beyond the partnership grant expiry. And there's been lots of other things that have happened in the sector to also support practice that we've been able to contribute to. And that includes, for the first time in Australia, we have national abortion clinical guidelines that RANSCOG produced, that the RACGP has endorsed. We have lots of other things, journal articles and things talking about abortion and LARCs and everything. So there is the evidence and the supports are catching up with what's required in the practice space. I'll finish off just by talking to you a little bit more about the coalition and using it as an advocacy tool. So when we wrote our Sphere application, we didn't actually put a coalition into the grant. But as I explained before, during COVID, things were so dire that getting together actually seemed like a good idea. A bit of stress relief, peer support, but also talking about how we could work together to effect change in that rapidly changing setting. But the Sphere Coalition has continued, and it now, we have a database of over 600 people. We have about 50 regulars who show up to an online meeting every 2 months. We have a formal agenda. I chair the meeting. We call for expressions of interest or concern, and people can bring issues to us as a coalition to talk about and try and problem solve together and come up with solutions. So, for example, one issue that's come up recently is a Medicare regulation that says that if you bulk bill a consultation, like the LARC insertions that we now have an incentive to bulk bill for, you can't charge for a consumable. So this was to avoid GPs charging patients for things like wound dressings. But copper IUDs, what are they? Are they consumables? Can you charge for a copper IUD? If you have a range of them in your practice, you sound the uterus to see how big the uterus is before you put in the IUD, and you make a decision on the spot which copper IUD to use. So the patient can't go and purchase that beforehand, but because it's being done at the same time as the IUD insertion, it might be considered a consumable, and then you might be against Medicare, and the Professional Services Review Board might catch you out, and you might be doing something illegal. So this is a problem. They brought it to the coalition. We've raised it with the government and asked them for a response. We're also dealing with Google bans on abortion. Do you know that abortion clinics, Google shuts down their advertising because it's got the word abortion in it? And so very excellent services providing telehealth around the country get their ads shut down when they're just letting people know that they're providing the services, right? So these are other issues that we can bring to government. So it's become a funnel for us to find out what the issues are and take them to the policymakers and to the colleges for advice. But it's also been an avenue for us to provide evidence-based consensus recommendations, and we've done that by putting in submissions to things like Senate inquiries, supporting colleagues fighting bad abortion legislation that's been tried to be introduced, like I hear what's going on here in South Australia at the moment. We did that for our Queensland colleagues. And it's been a very useful approach. So the coalition members are both individuals and come from various organisations, and they're a mix of clinicians, researchers, and non-government and consumers. So there's still a lot of work to do in this space. If we're going to really reduce unplanned pregnancy and make every child a wanted child, we've still got a lot of issues around different legislations for abortion in different states, lack of equity of access, particularly to surgical abortions in public hospitals, high costs for patients who really have to access care in private clinics. With the increase in medical abortion, we're losing the opportunity for women to have choice, because there's so many more medical abortions are being done, that less surgical, so there's less skill, so that's an issue we need to keep an eye on. We need to work to reduce costs for patients in both abortion and contraception, to improve women's knowledge, and really importantly to train our health professionals. And that's where that if there's something keeps me up at night, I worry about future GPs. Where are they training in these services? How are they going to support our patients of the future? I find this work tremendously rewarding. We've been very lucky, I think, to have supportive politicians that have brought policy change to bear, and I look forward to trying to address more of these wicked problems to get better health outcomes for women. Thank you.
Thank you very much. There we go. Okay, so we will take a few moments to take some questions from the audience. I'm sure there'll be several questions. I might start with a couple of ones that were raised online. There's two that I think we can get into one question, which is that the way it's been presented, it sounds like LARC's the answer to all problems. But of course, there might also be other elements regarding side effects, short and longer term, that are important to raise. So what is the evidence of any potential harm around the use of LARCs, and how do you try to transmit that important information to potential patients as well?
Yeah, there is a lot of concern about coercion towards LARCs, particularly in the US, where there has been, and in Australia too, there has been a history of a lot of reproductive coercion coming from health professionals to women to use various forms of contraception. So we have to be very careful that we don't become coercive in our conversations about LARC. And I'm often accused of this. Danielle, you're always pushing LARCs, and some women don't want them, and why should they have them? And I said, that's fine. I just want women to know about them, and I just want women to have the option as to whether they have them or not. And they can't have that option if we don't have enough providers, and they can't have that option if they don't know about them. But there are side effects with LARCs. There are a whole lot of risks at the time of insertion. There's risks of perforation. There's risks of ectopic pregnancy if a pregnancy does occur. But there are lots of benefits too in terms of heavy menstrual bleeding management, endometriosis management, and it's important At the moment, the conversation amongst consumers is all about contraception, but not necessarily about the use of hormones for the management of other common conditions in women. And we have a worldwide trend at the moment against hormonal contraception more broadly. The drug companies have been, when they've shown us their data, have been showing at least a 2 to 3% reduction each year. And, the journalists ring me up from the media and say to me, these are very educated women in their 30s often. Oh, none of my friends are using the pill. None of my friends would go near an IUD. We're going natural. We don't want any hormones at all. And I think there's this huge backlash against hormones being really driven by this misinformation. And then they're saying, how come there's been no research on what happens when you stop taking the pill? And I said, what do you mean there's been no research on what happens when you stop taking the pill? Oh, well, you get terrible periods and you can flood and you can... I said, but that's actually what happens often to many women anyway. It's like, there's this kind of very strange thing happening out there in the community about what's within the range and what's to be expected and the expectations of women around that.
Does anyone want to raise another question? Thanks, Rob.
So that was a really interesting talk, and it was very focused on women's health, but obviously it takes two people to get pregnant, and in the future sort of men's contraceptive things come online. How do you think that's going to change things, and do you have any thoughts on that?
Yeah, I think there's a lot of interest in male contraception, and that's a good thing. And I hope the products do come online. Some of my colleagues in Sweden and other places are involved in the trials of creams and gels and things. They tend to be products that require daily adherence, and so have issues around compliance and long-term kind of utilisation. So the issue for me around male contraception is really the issues about in what context are the men using those contraceptive products. They're perhaps more likely to use them in long-term ongoing relationships where there is a feeling of more responsibility in the partnership around pregnancy and the desire to prevent pregnancy. But for other men who are not in those long-term relationships, what's the driver for them to be using a daily product in that way? I think these issues haven't yet been fully teased out.
I'll take another one of the online questions, which comes back to LARCs, particularly their use in Scandinavian countries, UK, Ireland, where their use is much higher. Has that led to a major change in abortion rates? I think you actually did present some data there, but do we see increases or decreases in abortion in those countries where LARC use is higher? Yeah, so in the UK there's been slight increases in abortion rates. They're very socio-demographically determined in areas of disadvantage, and a lot of it's been linked to a decreased utilisation of hormonal contraception. It's a bit more unclear in the Scandinavian countries. It tends to be steadier rates. And I think Wendy's work is kind of interesting. In Canada, abortion rates are pretty steady. You mentioned disadvantaged groups, and another consideration that was raised in the online questions is, what about GPs and nurses who have different religious or cultural beliefs? How do you go about working with them and implementing some of these changes in where there is a really diverse set of opinions out there? Yeah.
Look, it's a difficult area. There are people with very strong beliefs in this space, and there is conscientious objection, and the laws are different in each state also. So in Victoria, which is the area that I'm most familiar with, conscientious objectors are required to refer on, to declare their conscientious objection and to refer on. The problem for women is that they don't know what the opinion is often of the practitioner that they're going to see, because they haven't talked about it before. And either that, or they don't have a choice of practitioner to go to. So a very important part of the equation, which I didn't really speak about all that much, is navigation to services. And this is where pathways, regional level planning comes in, healthcare pathways, where GPs can know where to refer to in the system, and also navigation for patients. So in Ireland, for example, they have a hotline, central booking line for the country for abortions. It's kind of 1-800 options, similar to the 1-800 My Options in Victoria. So women in Ireland who ring this number will be given the names and contact details of 3 GPs in their local region to make an appointment with. And the government in Ireland actually commissions services, abortion services. So they know where the abortion providers are. So commissioning is one way to approach abortion service delivery. And then the abortion providers are known, publicly declared. There's a navigation pathway to get there. In our system, it's a little bit different, but increasingly different states, and I'm not sure where you're at in South Australia, but in Victoria, for example, we have a website where practitioners can nominate that they provide services, or they may not put it on the public website, but the Women's Health Victoria knows who we are, and they will refer the patients directly to us so that that issue can be transcended. But when it comes to training, it's very important in medical schools to talk about abortion better, with some values clarification, with some better understanding for students about the fact that the numbers that I presented to you today, that almost 1 in 4 women will have had an abortion in their lives. So, these are, you can say, look around the lecture theatre tonight. There are a lot of people in the audience who have gone through this experience, students who have gone through this experience. It's a common procedure. And talking, normalising it, destigmatising it, talking about it being an essential form of women's health care. And it's unfortunate that from a generational point of view, for someone like me, I trained at the Queen Vic Hospital in Melbourne, which was a women's hospital, which a generation ago, maybe 2 generations ago, was filled with wards of women who'd had septic abortions from illegal abortions. But the younger generation don't see that. They don't know about that. And so telling them those stories and teaching them about the fact that, if you make abortion illegal, you don't stop it. You just drive it underground and make it unsafe.
So we'll take one last question, because I'm conscious of time getting away. Please, thank you.
Hi, Vivian Moore. Data from Queensland, I think put together in a journal article by Children by Choice, suggests that a surprisingly high proportion of women who access abortion have experienced intimate partner violence and domestic violence. I think it was upwards of 20%.
Yeah.
So do GPs and other people providing medical abortion need training so that they can intervene and potentially address those issues as well?
Yeah, so this is a really important issue. Thank you for raising it. Domestic violence is so common in our society anyway, but there is a very strong association between intimate partner violence and abortion rates, and we've published on that through the Australian Longitudinal Study in Women's Health. That's where we've been able to get our data from. And it's one of the arguments that I make why it's so important to have general practice as the place where abortion is provided. And my colleagues often tell me that GPs know the shadows. GPs know their patients, and GPs are well placed to provide that comprehensive holistic care that can address those kinds of issues, other issues, mental health issues, alcoholism. There's lots of other stuff going on in the background. I was at a dinner of the National Women's Health Advisory Council, which is now coming to an end, but we had our final dinner on Monday night, and one of the policy advisors, staffers, was saying that someone was going in lobbying government to say that abortions should be available through urgent care clinics. And I looked at her and I thought, I don't think so. Urgent care clinics are not the environment where you can get holistic, comprehensive care about things like domestic violence. It's what makes it important for it to be part of general practice.
Okay, there were, not surprisingly, more questions online. I haven't got an opportunity to ask. I'm conscious and thankful for you all taking the time out of your busy schedules to join us here tonight. But please join me in thanking one more time Professor Mazza for a fantastic and thought-provoking presentation. As a token of our appreciation, we have a little gift here for you. So this thing here, it's very well wrapped up. And it is surprisingly heavy, so Be careful. Thank you again.
Thank you.
And again, one more round of applause, and thank you all very much again for coming. Cheers.